and that there is a emerging body of literature that is very, very new and has a very limited evidence of good outcomes from taper programs. We did hear a large number of patient comments as well as outside providers that had concerns with this requirements. And then there's also implementation concerns that we've heard from some of our stakeholders. We received a large volume of public testimony. You all had access to that with the packet, but just in case you had any trouble with the PDF, we apologize. There were some glitches with it made it a little bit more difficult to read, so hopefully you were able to wade through it all. This is a qualitative summary of the types of feedback, so this is not a comprehensive summary of anything, but this is sort of what staff felt are sort of the biggest themes that emerged. There was concern that alternative therapies were not adequate to treat pain or don't work. There were folks who wrote about the benefits that they have received, either personally or if they were professionals, they'd seen their patients receiving from long-term opioid therapy in terms of improved function. And there was concerns with involuntary tapers from long-term opioid therapy, reducing function, increasing pain, concerns about increasing rates of suicide or illicit opioid or other drug use. There was folks who wanted to specify that chronic opioid use does not make you an addict. Proposed taper policy they thought was an overreaction to a few bad doctors, patients, illegal drug users, or it would vary by the specific email, but a few bad actor kind of thing. Personal stories of bad experiences with tapers, a feeling that this should be something that it should be decided between a doctor and a patient rather than through payer initiatives, and thought that this discriminated against low-income patients, OHA patients.
One of the other themes that I took away was kind of a combination of those two, which is that the involuntary taper creates an adversarial relationship between the doctor and the doctor who's trying to comply with the insurance coverage and the patient who they're trying to treat. That was a theme that seemed to come through quite a bit.
So on the original recommendations of non-pharmaceutical interventions, you mentioned that chiropractic is not covered, but they had recommended. And again, the mistake is being made that chiropractic is synonymous with a single modality, spinal manipulation. And so their recommendation was also physical therapy. That's a broad brush. That's not only a profession, but there's a whole cascade of interventions that fall under physical therapy. You might just as well say physical medicine. So passive, active, supervised exercise, therapeutic procedures, neuromuscular education, the modalities, mobilization, manipulation, manual traction, and then all the modalities, interferential, galvanic, yada, 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 all follow under physical therapy. And so to make the statement that chiropractic is not covered is an error. We provide most of all of these things are within our scope of license to provide, not just manipulation. So there needs to be some type of rewording that, in fact, when they say they've done to the evidence and physical therapy is effective, well, that's a broad brush. Right? What modalities, what interventions are they speaking of? And so, and most all of those are, I'm certain, are within the scope and licensure of naturopathic physicians as well. So there needs to be some amendment of that language of those recommendations, because we would not want this going through and the connotations of those interventions that fall under physical therapy or physical medicine are only to be provided by a physical therapist.
Is there a way to turn the speaker up? I'm actually having trouble hearing you guys a little bit.
Yeah.
And I know we have a couple of people that are hearing impaired.
Okay. We had this problem with our system. It can't hear it, and you turn it up 1 nanomillimeter, then it feeds back, so we'll try and keep that,
You can always talk
do that
louder.
down.
I
Yeah.
think that's always an option.
Yeah.
Hold it really close.
Okay.
So I
Okay.
wanted to point out that, G 89.0 is
Sorry.
already online preset.
Right. It's already a covered diagnosis, so the concern is whether we should move it. And then it would fall under all the limitations of the guideline for this specific. There's no limitations to it currently.
I see.
So in the interest of making sure we take advantage of the public participation, I want to make sure that we get first to our present. So our goal, so we're doing some of the work that we'll reserve for other meetings, which is the nuances of which codes and which scope and everything else. I think we want to make sure we heard a little bit more about fibromyalgia today and then let the public testimony unfold. So why don't we, are we ready to move to that?
So, Tim, can you come up?
Sure. I can stand over there. Is that really possible? I just can't see my slides well enough from over here.
Yeah, you don't have to sit.
Yeah.
As long as we can hear you.
So Dr. Kim Jones comes to us with 20 years of pain research experience at OHSU and is currently the Dean of Nursing School at Linfield.
And apparently having those credentials don't make you qualified to turn on a microscope. I'm not
Got a
gonna-
microphone?
Do you hear this?
No.
No.
How about not even?
No.
No.
Maybe
Yeah,
tomorrow.
pushed all the buttons we have.
How, I mean,
Here we
there's
go.
nothing, you guys can't hear anything.
Ooh, that one's on.
This one's hot.
It's literally hot, somebody's been holding it.
There you go.
Yeah, let's see, we should just go to slideshow, mode and hit from beginning. Okay, because this is a much pared down version of what I was gonna talk to you guys about. So a contemporary understanding really is that we used to think of pain in these 3 categories that never overlapped. There was nociceptive pain like osteoarthritis, there was neuropathic pain, and you all know what that is, where there's an anatomical lesion. And then there was this new thing called central pain, which would include fibromyalgia and irritable bowel and many back pains and headaches, etc. But what we've really learned in the last decade is that over time, most people don't stay in their pain category. These become blurred. Central changes occur in all of these pain states. There's now documentation that even people with osteoarthritis, which is a traditional nociceptive pain state, have central changes. So the idea is that there's not one kind of pain and that it changes over time. And it moves toward these areas that we see in fibromyalgia where there's central dysregulation. And we can see central dysregulation in fibromyalgia as a functional lesion as opposed to an anatomical lesion, and we can see it reliably on a number of neuroimaging techniques, PET, SCAT, fMRI, etc. So you guys are familiar with these. These are not new drugs. These are the FDA-indicated drugs that we have for fibromyalgia right now. Go ahead. And you're probably not also unfamiliar with the fact that if you're lucky, 50% of people will get 30% better. Not great, but it's not unusual for a first generation of drugs. Okay, so we have other drugs that we use in fibromyalgia that have an evidence base. So let's go on to that. Go ahead. So this is the category where we really have strong evidence for fibromyalgia, and it's the alpha-2 delta ligands like pregabalin and gabapentin, the dual reuptake inhibitors like the SNRIs. So one of the low-hanging fruit is to help transition people from SSRIs to SNRIs. Tricyclics and antidepressant agents, particularly at night for sleep. Sodium oxybate, really nice phase 3 trials, multi-center. It's on the market for narcolepsy and cataplexy, but not for fibromyalgia, but the studies were done in fibromyalgia. So if we move on to moderate evidence, I want to draw your eye to 2 of those drugs. The first one being tramadol. With or without acetaminophen. Those studies were done at people with fibromyalgia. When Ortho took it to the FDA, there was a decision that because nothing with fibromyalgia had gone through yet, that maybe we should not get it indicated for fibromyalgia. We should look for it indicated for moderate to severe pain. And you know that most of the life of this drug, it was not a scheduled drug. That's a more recent change that this was now a scheduled drug. The other one I would draw your eye to is this low-dose naltrexone. Only about 3 publications in this area, but very safe. Not fibromyalgia. It's not based on RCT data. It's based on animal models. It's based on other sorts of, based on RCTs. Let's move on. So where are we with the non-pharmacologic treatments? We have a preponderance evidence for 4 things: exercise, hydrotherapy, patient education, and a variety of cognitive behavioral techniques. And we have mounting evidence in acupuncture, diet, and mindfulness. And then we have a lot of piqued interest in herbs and cannabinoids. And another day we can talk about cannabinoids if you want, but right now 2 studies and then with the synthetics, and so it's not that level of evidence. It's this unusual thing. And get a terribly high medical bill and lots of unusual and unnecessary treatments, including surgeries that are not helpful. So being able to save fibromyalgia when a person has fibromyalgia is really important. Multimodal therapy is the norm. At a minimum, some sort of exercise and some sort of cognitive behavioral strategy, knowing that medications will be on board. So what about exercise? We have almost 300 trials now in exercise. As long as it's appropriately modified, this is really a mainstay treatment for fibromyalgia, not the only treatment, one of those 4 main treatments. Reduces lots of problems in fibromyalgia, but importantly, see that it's this mixed type exercise that's strength, flexibility, aerobic together, or strength training alone is really found to be effective now in fibromyalgia. Balneotherapy is something the literature is replete with this, mostly from other countries, because this is a standard way to treat chronic pain and fibromyalgia in Europe and the Middle East and other places. Keep going here. It builds natural resistance to muscle just to move through the water. The buoyancy may actually reduce nociception by acting on both thermal and mechanical receptors, and it decreases load on lower extremities. So this is something that, however we can help patients find access to, is really quite an effective treatment. Let's move on. So what improves in these land-based trials? The first one would be physical function or physical fitness, and at a decent effect size. What doesn't improve is sleep, so we really are still in the trenches about what to do about sleep and fibromyalgia. That's why we use CBT and medications in that area. What helps with exercise but isn't sustained after the trial is pain. So what's really emerging, go ahead, for sleep and pain are these mindful movement interventions, Qigong, yoga with mindfulness, Tai Chi, and land or water. But you can see these are very modified. Go backwards one. So this person is, on a chair, so she's not doing yoga that, you might just walk into any facility and see a person doing yoga. So it's very modified for fibromyalgia. But it's really helping pain, fatigue, sleep, and physical function. Cognitive behavioral therapies, we had this since the 80s, incredibly helpful. But then in the mid-2000s, like 2005, we really saw this preponderance of acceptance-based therapies come online, and in many places outperforming standard CBT. So let's move on. And this is why I think, so when we did standard CBT,
Speak up a little bit more.
okay, the mic went out.
Yeah.
If you hold it close.
Really close to your mouth.
This is really close.
Yeah, there you go.
I'm feeling very connected with my friend, the microphone.
I think one thing that can help with feedback is if the rest of us turn our mics to standby mode, that'll make it less feedback.
So is the hot.
Yes,
can.
We can turn off the volume a little.
It's
Sorry, I'm just
really
really
hard to
difficult to
hear
hear.
you guys still. I mean, even if we could just project a little bit, that would be awesome, guys.
Okay, how's this for projecting? Not projecting? Got it really close?
Yeah.
So traditional CBT really looked at anxiety, depression, fear, catastrophic thinking, and tried to turn those things around. But in the last decade, we have a lot of neuroimaging data about these techniques, these things that promote resilience and protective factors, social support, active coping, acceptance. So people, when they're allowed to know this is the diagnosis you have and do therapies that help you accept that this diagnosis is what you had, it helps stop, it doesn't just change your brain, which we see from imaging studies, it changes that cycling through the system where people are looking for more answers and more treatments, okay? Let's go on. So summary, here's where we have strong evidence: Tai Chi, Qigong, yoga with mindfulness, hydrotherapy, and acupuncture, which is almost in that strong evidence category. Move on. And this is where we have consistently small, positive, but safe therapies: EMG feedback, weight reduction with specific diets, manual therapies that didn't include manipulation, but Vern, they were exactly what you were talking about with all those other things that chiropractic practitioners can do for our patients. Massage, relaxation, biofeedback, mindfulness, hypnosis, guided imagery. And then what's not effective in the literature, herbs, nutraceuticals, Reiki, homeopathy, magnetic field, laser, and phytotherapy. So these don't yet have support in the literature. So then my last slide in summary is that chronic pain may initially be nociceptive, neuropathic, or central, but over time CNS dysregulation occurs in many people, and many people more accurately have this complex chronic pain syndrome rather than a single diagnosis. Most people do not keep their original diagnosis the rest of their life, but move into central states. So for treatment strategies, you need to provide the patient with the actual diagnosis they have and do that early. You need to normalize multimodal therapy. We need to use medications. We need to make exercise available to people, and enlist practitioners of cognitive behavioral and acceptance therapies early rather than late, and don't require that they have anxiety or depression in order to get to these therapies. And then we need to decide on what's really our best functional measure so that over time we're not looking at pain as the fifth vital sign, we're looking at measures of functionality. Thank you.
Any questions? You have a question?
I just took this on the run and pestered Kevin for just a second, but could you just go a little bit more into what a functional lesion is?
Yeah, so in neuropathic pain, you have a lesion in either in the peripheral nervous system, right, or you have a lesion in the central nervous system, like thalamic pain or MS pain or a spinal cord injury pain. That would be an anatomic lesion. In the central world, what we've seen is that on a variety of now studies, there are predictable areas where blood flow is abnormal, where neuroanatomy is abnormal, and it acts as a lesion just like an anatomical lesion would. So that's, Dan Claw has written about it, Rick Gracely has written about it. There's about 4 really good papers now. I'd be happy to forward you some of those as you want, is this idea that we have a functional lesion occurring in the...
I have a question just about how we make the diagnosis of fibromyalgia. So in my 20-year career, in the old days, it was a garbage can of
Yep.
call it fibromyalgia if you didn't know what else to call it. And then it turned into this thing that was so specific there was maybe 5 doctors in all of Portland who could actually make the diagnosis. And so are we clearer about how to really call fibromyalgia as opposed to a chronic pain syndrome, otherwise unspecified?
So this is the question of lumpers versus splitters, right? So we were being a splitter back in the 1990s when we said you had to have this specific kind of widespread pain and these requisite tender points that many people couldn't find, right? And so we went toward then this broader criteria, which was really patient self-report of a variety of signs and symptoms or symptoms. Since that time, we've been concerned about not sensitivity, but specificity of those tools. So now we have 3 more, and this year at the American College of Rheumatology, this newest one will be debated. So I think that right now what clinicians are doing is a combination of the 1990 and the 2011 criteria, but those are not the only way to diagnose. But I think importantly, what people need to think about is someone that comes in their office with a regional pain syndrome, just to understand there's a large body of literature that says most regional pain syndromes do not stay regional. They become more widespread. And to have only one or two areas of pain is really the anomaly, not the normal. But as clinicians, sometimes we think, oh, this patient has this one diagnosis, so that's what they're going to have forever. But really, that's not what we're seeing either in clinical practice or now in neurobiology.
Thank you. Vern, do you have a question? Good, you?
Hi, I guess I have a similar question related to diagnosis, because at least in the proposal for the line code, it's to include both fibromyalgia and then also like a chronic pain syndrome. And how do you delineate between those different conditions in terms of diagnosis?
Yeah, that's a good question, and it's one where clinicians are having to practice without an agreement from the scientific community about where we are on that. So for fibromyalgia, either the 2011 or the 1990 criteria is perfectly acceptable. Social Security, disability, third-party agents that look at disability accept those. But there are other proposals moving forward about body pain mannequins and how many areas need to be there and what's the best way to get a patient to endorse not just the most painful areas, but all the areas that are involved. So it's continuing to be a moving target.
And that was one of the things in the task force was the initial proposal was just to have chronic pain syndrome, but then their internal discussions where it overlaps a lot with fibromyalgia. So to not move that specific diagnosis, but to move chronic pain syndrome is difficult.
Yeah. There was a lot of that in the written testimony. Fibromyalgia was very prominently present in the written testimony we received, and so it's imprecise. I can understand why they recommended we lump them. Any other questions? Okay, so we're ready to go to public comment.
Thank you guys for getting up. I appreciate it.
Thank you. So what I've noticed in the and Daphne, are you gonna we gonna call people up?
Next, while she's bringing up the rest of the names, I did want. Go through those that were maybes on the get a definitive answer. Carl Probst, would you like to testify?
I would.
Okay, thank you. Stephen Hicks.
Yes, sir.
That was a yes?
Yes, sir.
Okay. And Amanda, is it Seeley?
Yeah.
Okay.
Check Julia off.
And so one of the things I've noticed is that just the act of transitioning between one to the next can take away time. So Daphne, if we could read the person who's coming up and the next person after, so the next person can get ready, it just makes it a little easier to get people in.
Or what about having two people come up?
We have two people at a time, so we can just kind of, yeah. I just want to make sure we don't spend half the time just waiting, hearing as much as we can.
My name is Tim Harlows. I'm late on the list, but because of constriction of time, you may remove my name from the list.
Okay. All right. And there will be more meetings, so if you're not able to testify this time, we'll make sure you get
There
your
wasn't going to be. Yeah, the only reason there are going to be more meetings is because you decided to put off that decision. So that's why we're all here.
Right. Well, that was our goal, is to make sure we can hear the public. So.
Right, but that's why we want to be heard, is because the decision was supposed to be made today, and so, we're here to make our voices heard, because this decision was going to be made today, and
I think if you actually listened or were at previous meetings, that's never been the plan. This is as Dr. Smits was saying, this is a big potential change to the prioritized list. There's no reason to make a decision before March. It doesn't go into effect until January 2020, and so we knew that this was going to take multiple meetings to decide.
Right, but you started out this meeting saying that you were delaying the decision that was gonna be made today, so.
Right.
I'm just raising
No,
my
it's,
case.
yeah,
That
it's
was just to let you know.
Yeah.
We were trying to clarify that no decision was going to be made today. I don't think there was ever an expectation it was going to be made. We had-
Okay, let's just keep going, we got our time.
All right, so just to give you all just kind of a flow, we will call up two folks at a time, just to sit at the table. We ask that you state your name. If you are representing any group, please state that group, and then any conflicts of interest that you might have. Being a patient or a provider is not a conflict of interest, but if you receive funding from any particular source or other conflicts that would be relevant.
And I apologize in advance for mispronunciations of names, so if I get it wrong, please correct me once you get up to the chair. Could I have Carolyn Concion and Bob Twillman? And again, after we hear your name and affiliation and conflicts of interest, I'll start the time, and then I'll give you the 60 seconds and 30 seconds in time indications. Carolyn, if you'll start.
And if we can put our mics on standby, that'll reduce our feedback.
Hello, good morning. My name is Carolyn Concha. Can everyone hear me okay?
Yes,
Yeah.
thank you.
I'm a nurse practitioner in private practice in Portland. All right. I have no financial disclosures. I've been a nurse for 28 years, 18 of which has been as a nurse practitioner, serving medically complex patients, mostly seniors and disabled who are homebound. I've observed the following. Patients have been stabilized on their opiates for many years. They were doing well and living life as best they could until their providers started tapering their medicines, oftentimes without a discussion or without their consent. So this directly impacted the severity of their illness, and it destroyed their lives. They were productive members of society. They were taking care of their kids, their aging parents, and for whom they were trying to provide care. But most shocking, these patients had been turned away by providers in their own community. I personally have 2 patients suffering from intractable pain that were rejected by at least 10 providers in their own communities because of their pain. And my question was just, how is this not discrimination? It's my hope that providers not feel fear every time they see a patient who's suffering, and it's my hope to continue providing care for patients, offering a customized individual plan that is best suited for them. I understand that there are individuals who are suffering from addiction to a medical problems, or an addiction unrelated to other medical problems. But dealing with this problem should not deprive chronic pain sufferers of medicine that's been proven safe and effective in keeping them as functional members of society. I don't think the answer lies in deprescribing or underprescribing according to artificial government limits, which ignore individuals' needs. I feel that patients who come to a provider for help and the provider does nothing, we become the tormentors. Primo Levi said that. He was a Holocaust survivor, and he's the one I'm quoting, that when a patient is going to a provider and the provider does nothing, we become the tormentors. That's all I have.
Bob Twellman. I'm the Executive Director of the Academy of Integrative Pain Management. The Academy receives a small amount of its funding from pharmaceutical manufacturers. I personally am a consultant with Millennium Health, which is a urine drug testing company. I'm here today to support moving chronic pain above the line, but to oppose the plan to implement forced opioid pain reliever tapers in those patients. I understand that you're in the 20th month of a similar 12-month plan to forcibly taper patients with back and spine pain off their opioid pain relievers. Clearly, the policy is not a rousing success, but there appears to be a willingness to impose it on another large group of patients. I think any such decision should be delayed until you have a clear understanding of the reasons why this plan has failed in that population. Specifically, I believe that you should do a thorough evaluation of outcomes experienced by patients whose doses have been tapered. What happened to their healthcare utilization and levels of pain and function? What happened with respect to mental health diagnoses, overdoses involving illicitly obtained opioids, and suicides? All of these questions and perhaps more need to be answered before you risk bad outcomes associated with forced tapers in yet another patient group. Only when you have a plan to prevent adverse outcomes should you consider expanding this policy. I also find it curious that improved function is a criterion used to justify extending opioid therapy for up to 90 days following injury or surgery, but it's given no consideration when it comes to patients who have already received more than 90 days of opioid therapy. Many of these patients have benefited from long-term opioid therapy and risk decreased function and increased pain if their opioid doses are tapered. Given your endorsement of improved function as a criterion for successful opioid therapy, it seems to me that any opioid taper plan should contain a provision allowing the taper to be paused, stopped, and/or reversed if lower doses are associated with poorer function. In fact, I suspect that one reason you've experienced delays in tapering back and spine pain patients is that many of them have decreased function associated with their tapers and therefore have slowed or stopped the taper. As the only organization in the country dedicated to promoting integrative pain management, AIPM applauds your efforts to improve access to a variety of non-pharmacologic pain treatments. We believe that we need to have access to all the tools in our pain care toolbox if we're to be successful in relieving pain. However, while your policy would provide several new tools to people with chronic pain, it would also take away an important tool, and we don't believe that's the right way to proceed. Thank you.
Karen Yergain and Geneva Lipton.
Can we let the patient that was gonna have to leave early go at some point?
Sure, would I have a name?
Who was it that had to leave early that needed to speak? They already
I
did
think Tim's did it.
Tim already go?
Yeah. So it's okay.
Okay,
Proceed,
let's
please.
keep moving. Karen?
Am I using this right?
Close to your mouth.
Is it on?
Yeah.
Okay.
Closer to your mouth.
Closer to my mouth even, is that better? Okay.
Louder.
All right. I'm Karen Yergain, I'm from Prineville, so I traveled 4 hours to be here today.
Thank you.
I am a public health nurse of 30 years, and I'm a chronic pain patient of 8 years. And I've been watching what's happening in the public health world as well as the chronic pain world, and seen a lot of struggles around this issue. What I can say is that in Oregon, according to presentations at the Oregon Epidemiology Conference in the last couple of years, including this year, at first the presentations were saying that the diversion of prescribed opiates was causing the opioid epidemic. Evidence now is showing that's not the case. Evidence now is that just like when I was a kid and saw the movie Crossing the Switchblade, the problem hasn't changed. Street drugs, illicit drugs, are driving the opioid epidemic. What we're seeing in Oregon is decreased prescribing of opioids to chronic pain patients. What we're seeing in Oregon is not a shift of chronic pain patients moving to street drugs, but we are seeing an increase in suicides in Oregon. The presentation at OREPI said that that needs a little more study to understand why. The presentation several years ago said we expected that. On a personal note, I'm upright in here today because I am on chronic opioid therapy. Without that, I would not be employed. Without being employed, I lose my land, my house, my home, and my sled dog kennel. Opioids keep me functional enough that I can not only be a public servant, but that I can maintain my personal life in a decreased way, but I can. So I want to urge the committee to really look at the fact that chronic pain does need to be recognized. It is not short-term, it is the rest of my life. My dad died from cancer. The amount of high-intensity pain was down to very manageable for him. I have hopefully another 30 years at least to go managing this. Thank you for your time.
Can everyone hear me?
Yes.
Okay. I'm Ginevra Lipton. I'm an internal medicine physician. I practice in Portland, where I have an integrative clinic about the need to cover things like acupuncture, massage, physical therapy, CBT. I think it's now fairly ironic that what it's taking to get this group to cover it is now the opiate epidemic, which is a problem. We all recognize that opiates are imperfect tools. They don't do a great job long term. We are having public health issues associated with it. If we bring fibromyalgia above the line, which we should have done years ago, and it's shameful that we haven't, we're the only state in the US that does not have Medicaid coverage for fibromyalgia. Now that we are bringing it, if we bring it above the line, we cannot do it in a punitive way. We cannot say, okay, yes, you have a real diagnosis, you have fibromyalgia. We will cover things like acupuncture and other evidence-based therapy. But we're the tool that has been helping you. And this is a monster of our own creation. The reason why so many Medicaid patients with pain are on opiates is because that is what has been covered. That is the only thing I've battle every day to try and get different medications covered that are evidence-based, but that are not. I can't prescribe it for somebody on Medicaid because they have fibromyalgia and it's not above the line. I cannot get physical therapy coverage. I have been on the front.
Very strongly, this should not go through. We will see a fundamental sea change in the pain management community relative to our capacity to help patients not only suffer less, but to be more productive and functional. When I was building pain centers, accredited pain centers back in the 90s and early 2000s, did that times two. The first program that I developed and co-directed, we got pretty much everybody off of opioids. And we got pretty good outcomes. The second program, right after that, in another hospital, we had a more flexible, customized approach to each patient. Our outcomes were far superior. When we had the latitude to judge the state of a given patient and be able to prescribe opioids on a long-term basis. Not everybody needs them, but for those who benefit from them, the empirical experience in clinic really should carry the weight of the day, rather than hypothetical construct or inadequate research. And finally, I just want to say this. There was a lot of discussion about the hyperalgesia issue, that if you take opioids for a long period of time, it actually amplifies the pain. 20 years of experience, I've never seen that. I've looked for it. I believed that common, or that conventional wisdom in the beginning, and I looked for evidence. I didn't see it. So I would like to say, disabuse anybody of carrying a lot of, or putting a lot of weight on that issue of hyperalgesia. Thank you very much.
Hi, my name is Carl Probst. I'm retired from the U.S. Army after 23 years. I sustained injuries during this time which resulted in 3 failed back surgeries. I have run the gauntlet of all types of medical treatment, including acupuncture, physical therapy, and the best treatment that I've received that give me a quality of life and not bedridden are long-term use of opioids, managed through medical physician. The Veterans Administration, out of the clear blue sky, has unannounced and just forced us to detox off. And there's a lot of weird things going on there. They are offering veterans use of a drug which I don't understand called Suboxone. And this is outrageous. My point today is only to tell you that I live a quality of life through the use of opioids. I have done this for years. Today, I am panicking. I'm trying to find help after the VA has let me down, and many thousands of other veterans across the country. So I'm here before you to say, do whatever we can to allow people with severe chronic pain to have a quality of life. Thank you very much.
Patrick, is it Starnes? And
I'll start right away while
Stephen Hicks.
Stephen's coming up. I'm Patrick Starnes. I drove up from Brownsville. I'm not a chronic pain sufferer, and I'm not a healthcare provider. But in full disclosure, I am running for governor as an independent candidate.
Yay!
But that's not why I'm here. What I want to help do is get some focus. Being an outsider of the community, I think I can help. But first, I want to thank you all for volunteering, if you do, and if you've been working at this for a long time, I really appreciate it. And I also want to help thank the care providers, especially Dr. Jones, if you could pass these out. Your point about splitters and lumpers, as one of the first points, is let's not lump the addicts that steal their grandma's medicine from the chronic pain sufferers. And then for the media that's here, you need to follow the money on those drugs they just mentioned.
Yep.
But mostly, if Ariel, if you could help me pull up the chronic pain list, the task force. people on that? Because being an outsider from this community, I can't help but recognize these people are not here on this list.
Yep.
Nor are there,
Not one of them.
nor are there health providers. They need to be there, and since their next meeting is September 20th, I want you to do anything you can do to put some pressure to have those 2 seats. Because as you go to their comments, if you go to Ariel, the public comments that they posted up there, those could have been included earlier, right? If those two seats had been at that table. So I just really, being a system analyst kind of person, you've got the cart before the horse here, and you really need to get, and I really appreciate you guys postponing any decisions. Because this is crucial that these folks have a voice, and that's why I've stepped up as a voice for the voiceless on other issues too. I just really, it's important that they have a seat at that table, or at least their care providers do. And thanks for making that happen. Before September 20th, when they meet, they should have these 2 seats. Thank you.
Hell yeah, man. Thank you.
Hi, my name's Steve Hicks, and I'm grateful that we were able to get together and show some solidarity. All sound great, and I can assure you that I have tried all of these ideas with very little success. The very first thing that I've done in the last 14 years to have any sort of progress has been water therapy, this hydrotherapy. I didn't even know that it was a thing. I've been through failed surgeries. I've tried physical therapy to the point where they just said, there's nothing more that we can do for you, sir. It's very disheartening, and it's hard on the head, and it's really easy to become depressed and lose hope. And the one thing that you have is at least you don't have to suffer the darn pain so much. So I guess what I'm getting at is that the people that are the most vulnerable people in this country, including veterans, it's our duty as United States citizens to take care of the people that are suffering. The idea that somehow taking away people's medicine and that it's magically going to go away, it's simply not true. I gotta tell you, the people that I have met fighting for human decency has been a transformation of my life. It's been the privilege of my life and the culmination of my life's works to be here today, fighting through the pain, because it's so important. There are so many people that want to be here so bad, but they're scared to death. They don't want, if they do have a doctor, they don't want to bring up, they don't want to talk about it because, heaven forbid, they get their name red flagged like I did. And once you've been identified, as a drug seeker, it's a real problem. You know, it's demoralizing to have to beg for help. We pay a lot of money for private insurance, a ton of money. This year we've spent over $20,000 out of our pocket after our gross income. Okay, we get taxed first by the federal government, a good chunk by our state government, not anything. And I just don't quite understand. I need help.
Thank you.
People, there are a lot of people out there that need help. This is bankrupting our community, not only financially, but spiritually and physically.
I'm sorry, we have to.
Okay.
Thank you.
Thank you for your time.
Thank you.
Amanda Seavey and Helen Turner, please.
All right. Go ahead, sweetie, you go first.
I'm Helen Turner. I am a clinical nurse specialist with Prescriptive Authority, and I care for children with chronic pain. And I'm also a past president for the American Society for Pain Management Nursing and an ad hoc board member for the American Academy, or the Academy of Integrated Pain Management. I also do consulting for prescriptive practice questions at the State Board of Nursing. And I've been doing pain management in children for over 18 years, and although I recognize most of this is targeted at the adult population, whatever gets written into the guidelines, the rules, whatever, affects the children I care for. Because the pharmacists who do the prior authorizations all say, well, this is what it says, and I can't do anything about it. I care for children who have sickle cell disease. I care for children who have something called Camaraderie-Engelmann's. There's 200 in the world. The primary symptom is pain. And if you ask me to stop prescribing opioids for the children who have been able to go to school and have quality of life, it will be a disgrace to this state.
Absolutely.
And so I ask you, please, the evidence is messy at best. And it certainly doesn't apply to all patients. I've been at the Hill in Washington, D.C. trying to explain that yes, we recognize the opioids have caused a problem. And yes, we were the prescribers who caused that because that was our knowledge at the time. We didn't think it was going to be the problem it is. We're now backpedaling. I'm trying to get as many kids off of opioids as I can, but there's some that will die if I do. Thank you.
My name is Amanda Seavey. I am a complex regional pain syndrome patient, and I have been for 5.5 years. I represent a group of patients known as Patients Not Addicts, and I represent Disabled Americans for Change. We have zero finances and zero financial interests. This is all about patients for us. This is about my life and their lives. So that's why I'm here today. And I'm a really visual person, so I wanted to show you something. These are my medical records. This is 5 years of treatment for CRPS. This is every bit of alternative treatment I have had. This is PT, this is OT, this is acupuncture, this is massage, this is everything I have done. This is 5 years of prescriptions, gabapentin, Lyrica, Cymbalta, everything, Tramadol, all of it, every single bit of this got replaced with that. What is this? This is methadone. That's the only thing that takes care of my pain. Without this, I am dead. Because this, all of this, that did crap for me. Nothing. It made me sick. It gave me side effects. It almost killed me. I lost my hair. I lost my dignity. I couldn't get out of bed. I had no functionality. I had zero hope. That is my hope. That is what saves my life. And the only thing you are doing by taking it away is driving patients to the street, to the bottle, or to suicide. There are too many patients committing suicide when all that they need is to continue their prescription. That's it. They just need their meds. You guys are taking away their hope, their functionality. You are giving them nothing in exchange. We have rights. Less than 3% of chronic pain patients become addicted to less than 3% and addiction prior to their onset of physical pain or prior to the onset of chronic pain. It is super easy to tell who is going to become addicted because they have problems with addiction prior to their onset. My genes make me an addict, and I don't have those genes. Don't take away my meds. Don't take away their meds. We have a right to hope and to functionality. You guys can roll over in the middle of the night.
My name is DJ Cap. I'm Associate Director of One for Chronic Health. We are a advocacy and policy organization that works on behalf of patients living with chronic health conditions. To the best of my knowledge, we are not seeking nor have we received any funding from any organization that specifically markets a opioid-based pain product. For that, I wanted to talk a little bit about our concerns for this rule. As you well know, many patients living with chronic health conditions have either acute or chronic pain syndromes. We're very concerned about the limitations that would be placed on the access to pain medication by guideline rule 16. As we propose the requirements, we would recommend alternative treatment modalities, and we do appreciate that. Let me just preface this by saying I want to congratulate you and her for recognizing the impact of opiates, even with people who are misusing them by prescription, and what that does to add to our current opioid abuse crisis. However, pain patients are not addicts and shouldn't be stigmatized as. There's concerns about how we would implement such a status. For example, from the June 7th meeting notes as to the chronic pain task force, Dr. Smith herself stated that evidence is inadequate to support Tai Chi, but slightly stronger to support mindfulness therapy. It's our belief that limiting opioid therapies with the goal of eliminating their use is completely premature at this time, and in fact is in opposition to CDC recommendations.
It's our belief that limiting opioid therapies and eliminating their use is completely premature at this time, and in fact is in opposition to CDC recommendations to treatment of pain. Chronic pain patients are really stigmatized and discriminated from others. Opioid prescriptions are monitored in Oregon by the Oregon PMDP, the Prescription Drug Monitoring Database, also monitored at the federal level. We're doing an excellent job of monitoring the access to medication for patients. One more opposes Rule 90 and restrictions limiting the ability of providers and patients to choose the best available treatment for them on behalf of patients living with chronic pain, including myself. We're demanding that we are no longer blamed for the opioid abuse crisis. This is an active policy at the state and federal level that hinders a patient's access and ability to receive the treatment.
My name is Julia. I don't think I need it. Can you guys hear me? Okay. So, is that better? Yeah, we got you. All right. My name is Julia, and I'm here today because of this woman back here, my partner in crime, little ally, Nicoletta, who has been sitting in on all y'all's meetings.
I don't think I need it. Can you guys hear me?
Heck
yes, use the microphone.
Okay, so is that better?
Heck yeah, we got you, girl.
All
right, my name is Julia, and I'm here today because of this woman back here, my partner in crime with a little hat on, Miss Amara, who has been sitting in on all y'all's meetings since 2016, gathering all the information that she could find as a chronic pain patient herself, and quickly became an advocate. And her and I met, a month and a half ago, maybe? And she said, I got all this information, I don't know what to do with it. And I said, I got a big mouth, I'll get it out there. And so the two of us teamed up, and that's why you guys are voting today. We helped to generate all the comments and public interest because this was not public knowledge. This was not something that most people knew about. They knew that they were having trouble with their prescriptions and getting their prescriptions, but they didn't know that they had the potential to lose it and go back to therapies that, quite frankly, all of us have already tried. I personally had a new eye that they tried to build me from the outside or from the inside out. It didn't work. I've had multiple surgeries. I've tried over 40 different medications, procedures, injections in my eye while awake, staring at my husband, telling me to hold still while they shove a needle in my eye, trying to numb my optic nerve. I have tried ketamine. I have tried acupuncture. I have tried gabapentin. I tried every opiate for 6 years, every non-opiate medication that was at my disposal. Not one of them gave me relief. By the time that they finally had given me my first prescription of pain medication, I had already written letters to my husband and my son and had made my decision to die. I could not live like that anymore, and I will not go back to living like that again. And you can't possibly understand what it's like. In my situation, it's my eyeball. And when it hurts, which is hurting right now, not bad enough that I can't speak, but there are times when I can't complete a thought, I can't complete a sentence. The only thing that I can do is pay around in circles and pray that it goes away. I have it 2 hours a day, 7 days a week. That is manageable with opiates. I also have acute pain that strikes whenever he feels like coming up. And when he hits me, I literally hit the ground. And those attacks can last anywhere from 2 minutes to 10 days. And you have no idea what it does to your psyche when all you can do is just wait for relief.
Yeah.
Dr. Smith, may I just briefly offer that, I've worked with this community for a number of years now. I've gotten to know a number of you. You're good people. I understand that what you're trying to do is in the best interest of the people and patients of Oregon. And I hope that we can continue to work together like this with input from the community. With the patients. To find solutions that help to address the misuse and abuse of drugs, address our overall public health crisis around opioid use, and still are able to allow patients access to medication they need, and in cases where alternative therapies are available to those as well.
thank you all for your comments. We really appreciate this. And so we'll let the process continue to work through the committee. We'll be back
in October or November to this group. A longer case scenario would be that they need more than one meeting to come up with a revised proposal. So we will either we'll see it at some point, October, November, January. We definitely will need to see it by March. My hope is that we get to have it early in the year here so that any changes or other things can be done before HERC sees the final proposal, because they may need one or more meetings to look at it as well. The final deadline would be the March HERC meeting. And then the implementation would be January 1st, 2020 for any changes we make.
So, wait a second, can I ask, I'm sorry, for chronic pain patients, what does that mean to us? Does that mean you're gonna wait a month or two and then make a decision? Or are you gonna let us know before you decide? How is that gonna work?
So all of our materials are available at our website, and you can sign, there's a...
And our deliberations are, so all of our decision-making will be just like it is here, and the dates of those meetings will be published, and the agendas will be published, so.
So at the end of the meetings, are you gonna like do a vote and then hit the gavel and that's that? Is that how we proceed from here?
Yeah, so we're advisory, so that the task force is advisory to us. This committee is a subcommittee of the HERC, which is meeting this afternoon. And actually, that gavel is the final decision, right? So we could say.
That this isn't gonna get passed by without us knowing.
Yeah. So the way you can do that is to keep an eye on the website and the agendas, and the meetings are all open to the public. And
all of our meetings for the duration of the existence of this commission are announced weeks in advance, so 28 days in advance, has a list of all of the topics that are going to be discussed. In some cases, we list some topics that we think might be discussed, just to be safe. And then as the meeting draws closer, we decide, we're not going to be able to get to that one, and so we cross them off. But we give all that notification 28 days in advance. You can go up to our website and sign up for electronic notices of our announcements.
So my big thing.
Yeah. So our intent, our intent is not to do that, and but the way you can stay engaged is to keep an eye on that website and the agendas. That's the way.
So we will be all over that.
And you can sign up to be on a mailing list as well, so it will push. This is the meeting coming up. This is the agenda. If that is a preferred way for you to get the information, or you can just go to the website.
Are we going to need to sign up for an invitation, like how we needed to do to send in our comments? The ones that you've received that I needed to be in, I think it was by the 30th.
You're always welcome to send in comments. We have a deadline in terms of when we tell the commissioners these are available to look at, and that's just...
When is that deadline?
So we send out our packets to our members a week before each meeting. And so the best time to get them in is about 9 days before the meeting. So say so if our meetings are always on Thursdays, and so the Tuesday before the week of the meeting is the best time to get them in, to make sure that they'll be able to see them at the same time they get the packet. We do accept comments up until noon the Tuesday right before the meeting, so 2 days before, just but it's best to get them as soon as possible.
I'd like to ask you a question. I had a question. I have a little, like this small
Okay, we have to move on, thanks.
Note 60 was crossed out. When is that going to be dealt with? Note 60, or back and spine and neck, that was crossed out from the agenda today. When was that going to be discussed?
I think that'll be one of the ones that we'll look at being able to get to in October 4th would be the plan at this point.
But not September.
No, not September. No, that was on the agenda for this committee.
In the body one more time?
The Palliative Care and Interdisciplinary Quality of Life Advisory Council. All right, thank you.
Say that 10 times fast. Okay, so we're not done.
There's messages back to the task force, and again, it's one of the effective treatments being physical therapy. You heard my comments, and Ariel started off by saying, well, chiropractic is not one of those. Well, we're not a single modality, but that message back, that needs to be clarified and expanded to understanding that the great majority of these modalities, these interventions are within our scope of life. I provide them every day. So that would be my message.
Vern, the guideline just doesn't have the CPT codes for spinal manipulation. It doesn't actually say no chiropractic. We just wouldn't be including those specific CPT codes. So if a chiropractor uses a different physical therapy or office visit CPT code, it would be included. Yes. Yeah.
Okay. All right.
Take a long, hard look, because this take a long take a long, hard look, because this is the face of the opiate crisis. Today, I am going to bring up an extremely controversial subject. I ask you to put your previous misconceptions, your generalizations, and the things you thought you knew to the side. There's a possibility that this could one day affect you and your loved ones. And if nothing else, you'll leave this video a little more informed. I can do two things here on my channel. I can hide my struggles, or I can document them. And ultimately, that is what I came here to do. I came to YouTube to form the community that I saw the world lacking. A romanticized narrative of chronic illness helps no one. And if I let fear dictate the topics I choose, then I will never bring the change that I wish to see for my family on this platform. I know the ways that I myself have suffered in, and I believe my greatest mission in this world is to eliminate the obstacles that enabled that suffering, to make sure that no one else suffers in that same manner. I have to start by telling you that I began my life with an overwhelming fear of addiction. I grew up swearing one thing to myself, that I would never partake in addictive behavior. Even as an adolescent, I swore to myself that I would never let my child see the evils that addiction can consume. It's important for you to understand that I have kept that promise, because I do not suffer from addiction, and yet stigma will tell you that I do. And that is a myth that we are going to change. That is a myth that we are going to change today. Regardless of that fear, I was diagnosed with a disease that has no cure. It has no treatment. My illness is characterized by unrelenting spasms and pain. My muscles can use such force against me that my bones are broken. And if you've seen my previous videos, then you'll know that this disease made both of my lungs quite literally pop. I'm telling you the dimensions of my disease for one reason and one reason only. Because I want you to understand that you can have whatever bias you choose in regards to opiates. But the truth is that you will never reach an unadulterated understanding until you find yourself with an excruciating need for them. I hope to God you never find yourself in that position. But I ask you to take this issue seriously in the event that you may, in the event that you could. Because the scariest characteristic of chronic illness is that it doesn't discriminate, and that you'll never see it coming. Don't ever brush off the fight of the chronically ill, because your lives can change in an instant just as ours has. Sometimes, when considering an issue, we have to ask ourselves, what if, in order to accurately determine its importance. The rarity of my disease leaves me with one lifeline, one treatment, one means of normalcy, and that is opiates. And this shatters most people's belief system. Chances are that that statement sparked anger in some of you and confusion in others. And honestly, it's difficult to say which emotion is worse, because both were born strictly out of ignorance. I use the word ignorance without any negative connotation or derogatory air. Instead, I use it as fact. The fight against opiates is an uneducated one. This is a movement that lacks understanding in its most basic form. Every lawmaker is taking on this fight without ever consulting even a single chronically ill person. And what does that mean? That means that the people that depend on these medications aren't even being considered when taking them away. For someone like me, you're not limiting my access to dangerous drugs. You're limiting my access to life. And there's hundreds of thousands of me out there. There's millions of me out there. Before we begin, I think it's important for everyone to understand that fentanyl belongs to the classification of opioids. Yes, fentanyl is a life-saving prescribed medication that helps thousands. However, most only understand it to be a potent and deadly drug without realizing that most fentanyl is illegally made rather than prescribed. Because it has become a common additive in heroin and therefore has developed an illicit street presence, it has grossly overestimated opioid statistics. Bear in mind that statistics pertaining to prescribed medication are not measured independently, but instead are grouped into the same quantifiable method they use to track overdoses on illegal fentanyl. Deaths of alternative causes, be it other drugs or natural causes, are also included in these numbers, making the facts of the opioid crisis largely unfounded. In a time when human rights is at the forefront of our societal obligations, we have forgotten the human rights of the chronically ill. You wouldn't take away a diabetic's insulin, but you will take away my opiates. Maybe that seems like a far distinction, but I promise you it's not. Insulin carries the potential for misuse, but yet we have to consider that the lives that it saves prove to be a benefit that far outweigh the risk. And in that way, it is a fundamental of our human responsibility to be informed enough to understand the difference. When you hear the word opiates, you think of needles and filth. And when you hear of an opiate user, you think of someone losing their job, losing their homes, losing their families, and losing their everything. Instead, when you hear the word opiates, I want you to think of a mother at a park. I want you to think of a parent that made it to their child's graduation when they wouldn't have made it there otherwise. I want you to think of someone being able to finally hold a job after years of debilitating sickness. I want you to think of someone who kept their home because they were actually able to get up and provide for it. You associate opiates with hopelessness. I associate opiates with hopefulness. I ask you to honestly consider if taking away someone's drug of choice is worth taking away someone's quality of life. I am not naive to the happenings of the world, and I am under no false impressions regarding the heroin epidemic. I hear the mothers and fathers and brothers and sisters pleading for a call to action, but this is not it. These lawmakers and reformists are acting out of concern for the addict rather than the patient. I am not telling you that one is more important than the other, but that's just it, isn't it? The addict takes no precedent over the patient, and the patient takes no precedent over the addict. But when a patient has their opiates taken away, you are telling them that they do, in fact, come second. You are taking away a human being's right to live comfortably. You are taking away their medication to treat an illness that they suffer from at no fault of their own. Are you willing to do that? Until someone has found a way to control the epidemic without hurting the chronic pain patient, there cannot be any implemented reform. Because I promise you that you are hurting more lives than you're saving. You need to consciously consider every child whose parent can no longer rise from bed to play with them because of negligent reform. You need to think of every human being who now contemplates suicide after years of being able to appropriately manage their symptoms. Does the mother that lost her child to addiction cry any louder than the mother that lost her child to pain? In a time when the world is consumed with breaking down stereotypes and generalizations, we have managed to demonize opiates in a manner that seems almost beyond repair. While we are fighting to end the practice of stigmatization, we are consciously allowing an entire portion of the population to be stigmatized, all the while being fed inaccuracies to believe it is both justified and crucial. When did a person's prescribed medication become a source of humiliation? When did a drug that could effectively reduce symptoms and greatly increase functionality become any less of a miracle? When did a negative association become enough to end a discussion? Opiates have been vilified in the media and by its actively demonstrative opponents. They are suddenly the monster hiding under your bed, the poison lurking in your medicine cabinet. And the crusade against opioids seems to include the same irrational arguments as a bad political campaign. It is of extreme importance to briefly discuss the vocabulary used in the discussion concerning controlled medications. Terminology is often thrown around without the basic knowledge of meaning. Two words that are often used synonymously and could not be more different are addiction and dependence. I believe one of the most frustrating components of this argument is the belief that with one inevitably comes the other. Opioids have been made out to be the instrument of the irresponsible, and therefore we have been taught to believe that they cannot be used responsibly. Yes, it is true that a responsible opioid user will experience physical withdrawal without their medication. But so will an individual taking prednisone for an extended period of time. So will an individual taking antidepressants or benzodiazepines, and the list goes on and on. Withdrawal is not synonymous with addiction. It simply means that the body has developed tolerance and a physical dependence on a certain substance circulating throughout the body. Please try to understand the simplicity of this argument. If a patient is experiencing chronic pain, they will need to chronically take a pain medication. Does that make them an addict? No, it means that they have fallen ill with a disease that is relentless. Let's discuss another two terms: medicine versus recreational drugs. How would you feel if I called your blood pressure medication a dangerous drug? How would you feel if they were cut in half solely because people had found a recreational use for them? Of course it would. You would tell me that you use it responsibly. You would tell me that it's of medical necessity. Well, I feel the argument against opioids to be equally as ludicrous. And so does the rest of the chronically ill population that's living in chronic, debilitating pain. While we understand the need for regulations, we can't possibly understand why we're being punished for another's misuse. The truth is, when you live in chronic pain, an opioid high is unfathomable. Why? Because we have such severe pain to treat, and that drug is working on its intended use. The only person we harm by taking more than we're intended to are ourselves, because that means we will have days marked by such sheer agony without remedy. As the chronically ill population, we do not know the meaning of pain-free, and our prescriptions are simply a tool we are able to utilize to take us from unbearable to manageable on a good day. Without them, our good days are a sheer memory, and our quality of life will cease to exist. You wouldn't let your dog suffer with no quality of life. Yet you'll let a human suffer in the name of a cause. As an intelligent population, we understand the difference between action versus reaction, but somehow lack the basis to rationalize when the conversation pertains to narcotics. Today, we are told that addiction is a disease, and regardless of whether or not you believe that, I ask you to apply your knowledge of cause and effect. Is the drug with potential for misuse the problem, or is addiction the problem? We quickly blame a drug because it's easier to eliminate than human dependency. Would taking a person's opioids away today prevent an overdose on heroin tomorrow? Of course it wouldn't. Yet it's a quick solution that gives some of the population more comfort than the thought of doing nothing. There are a multitude of drugs that carry the potential for misuse. And if we don't treat the underlying issue, then addiction will always find an outlet. As I film this video, thousands of chronically ill patients are being forced from their regular medical care providers. Thousands of pain patients are being torn from the doctors they have spent years building relationships with and filed into pain clinics at an alarming rate. Pain clinics have one main objective, and ironically, it isn't managing pain symptoms. Instead, it is formulating a plan to eventually rid someone of their controlled medications. Maybe you think that's acceptable, and if you do, then you haven't considered a very large percentage of the population. Because some people, like myself, cannot be taken off of opiates. Instead, my life will have to consist of being on them. And yet, these people haven't been considered. There's nowhere for us to go where we will be met with the compassion and understanding that's necessary to continue living. What ended this compassion, you may ask? The stigma that has been created surrounding opiates and their use. Modern medicine has made such amazing strides, and we are living longer than ever before. For many, that means the use of daily medication. If someone's life is plagued by pain, why is pain medication not considered revolutionary and miraculous? How sad that the term drug seeking has become vilified enough to end discussion and fair treatment of patients in an instant. Even if this terminology is both unfounded and the result of a bad practitioner, the patient has no legal recourse without fear of looking irrational. It's easy to forget another group of unfortunate victims of the opioid crisis, and that is good doctors. Unfortunately, this crusade has impacted them just as severely as the patients they strive to treat. Once upon a time, a doctor was encouraged to build a relationship with their patient, a relationship that could identify medical necessity and deter misuse. However, since a generic 1 milligram fits-all mindset has been enacted, the doctor-patient relationship has lost its importance. We understand that one medication cannot treat all diseases. Why then would we believe that one specific milligram is suitable for all patients? We know that one size certainly does not fit all. Yet federal organizations and state governments have enacted morphine thresholds and ceilings. Chronic pain has no ceiling, so how can its dosage? As a result, we have bred an insurmountable fear in medical professionals across the country. They are faced with the decision of helping patients or potentially losing their practice and or ability to write controlled prescriptions. Are doctors suddenly expected to refuse patients without alternative options and allow them to suffer for what the public would claim to be the greater good? Practicing medicine should be just that. It should be treating patients and helping the ill, and it is explicit in the oath of do no harm. Instead, doctors are being forced to make a choice, and patients are being abandoned without hope. They are being forced to act selfishly or selflessly as they save the patient or save themselves. For every bad doctor, we have given them the proper ammo to refuse treatment with vilified terminology, and for every good doctor, we have tied their hands behind their back and taken away their instruments that once proved to be life-saving tools. And this brings me to perhaps the most important point of all. This is what the lawmakers and those calling for reform have failed to consider. The opioid crisis is driving the street market. Let's repeat that. The opioid crisis is driving the street market. I beg you not to shake your head at this, and instead to open your mind despite the stigma you've learned. What I think the majority of the population fails to realize about opiates is that there is true medical necessity for them. For some patients, opiates are their only chance at life. And for a chronic pain patient, life ceases to exist without their pain medication. If new social practices and government reform has forced a dramatic cut or actual removal of narcotic medication from a patient in need, their quality of life is gone. When faced with the choice of life or death, which would you choose? When faced with a life of agony or fulfillment, which would you choose? Once you have taken away someone's legal source of a necessary medication, they are forced to find an illegal source. These people are not drug addicts. These are patients that choose life and have lost their ability to live it. These are people that never knew the name of a drug dealer. These are people who never wanted to participate in illegal activity. And yet you force them to buy their medication because someone says they can no longer be prescribed to it. Finally, I want you to understand that if you are not familiar with chronic illness, that quality of life is not synonymous with life. Some may say you're lucky to be alive, and the chronically ill population would answer with, then you've never known the grasp of chronic pain. Living in agony is not living. It is simply existing. Chronic pain is torture at the hands of our own bodies. It is the inability to think. It is reminding yourself to breathe. It is remembering reasons to live. Just because there's a heartbeat doesn't mean it's happy. I realize that this is a topic. And that means that this campaign was and continues to be effective. Just listen to the language. No one says the heroin epidemic. Instead, they say the opioid epidemic. This issue has been so effectively stigmatized that it is impossible to speak on it without fear. The word opiate alone is capable of inciting mass hysteria, when for millions, that word is a beacon of hope. When you take someone's opiates, you are taking their life, and yet they cannot show frustration or anger without being labeled as drug seeking. None of us asked for this, and we would trade every last pill for one day of normalcy if we can even remember what that feels like. We want health, not drugs. We want normalcy, not pills. And yet some means to another. We hear discussion in terms of acute pain, but never chronic. And it's time we open the discussion to those who are truly being affected. We need to accurately understand the dynamic between opioids and quality of life. As a golden rule. Yet we fail to implement it when fear is effectively attached. Chronic illness is a massive problem, and chronic pain means that some people live every second in a state that most would consider unbearable. Changed forever. Their days consist of a fight to live, a fight to want to live. For these people, there is one source of hope. And I beg you to consider why that can't be taken away. Without pain relief, the rate of suicide will surge higher than ever before. Until an individual has experienced chronic pain, they cannot understand the constant fight to survive it. The world seems to have forgotten that opioids are medicine. Medicine that many cannot live without. As you watch this, someone is contemplating suicide. As you watch this, someone is physically trying to hold themselves together because their prescription was either significantly cut or taken away. These people are sick, and they're not getting better. In most situations, this is a problem that will plague them for life. Give them a chance to live it. It doesn't matter how strong they are. It doesn't matter how tough they are. No one can live in agony. Don't abandon patients because mass hysteria tells you to. Remember that chronic pain patients are people. They are human beings, fighting to live. and that will never be synonymous with a drug addict. People say 2 wrongs don't make a right. So don't take one life to save another. Keep being warriors. For every woman with stage 4 bone cancer who has had her opiates cut, for every man with ALS who's had a pharmacist shake their head in disgust, for every person who's gotten frustrated by stigma only to be referred to as drug seeking, for every woman that's gone to a pharmacy only to hear whispers, for every patient that had a doctor make them feel worthless, for every human being suffering because of opiate reform, I'm here to tell you that's wrong.
Hey guys, so listen, I just did a video and I just got done reviewing it and it's spliced up into a bunch of pieces and I really don't know how to use iMovie
13 Investigates has discovered a secret at drugstores all over the...
splice it back and you're gonna know. Hey guys, so listen, I just did a video and I just got done reviewing it and it's spliced up into a bunch of pieces and I really don't know how to use iMovie yet. So I'm going to do my best to splice it back and you're going to notice that I'm going to start out of nowhere. And that's because I'm getting rid of the beginning part of it because it was dry. And I'm just and I really want to get to the emotion. So what you're going to see is the real me. Yeah, I'll do my best to splice it, but just know that I was reviewing an article that this doctor wrote. It's not important. I think what's important is what I did. So watch it. I hope you enjoy it. Thank you very much. I hope y'all have a good day. Bye. It says that the people that went on this retreat they were between the age of 26 and 72, and for their average duration of pain was on average 15 years. They describe it as daily discomfort. Now, I don't know about you guys, but this is not discomfort. Discomfort is like when your pants are too tight. To me, that's discomfort. This is like daily life-altering, miserable, relentless pain. And I think that a lot of the issue with people not understanding where we're coming from is that they just think that we're dealing with discomfort. Like, you know, like when you stub a toe or you kind of jam your finger. Have you ever jammed your finger? That's discomfort, you know? This is like, I get up and I can't move and I'm like creaking around. It's bad. So I don't get that. So that answers my question of why these people were able to get on the floor. They weren't comfortable. So she says, all of them, no matter what their background, shared one common sentiment: a drastic sense of isolation and shame. I have some thoughts on that. The very system that's supposed to be taking care of us causes the sense of isolation and shame. We feel shamed every time we go to the ER and we're discounted, or we're turned away, or we're told we don't treat pain. You know, I've got a family member who works in the medical field, and there was a patient. She's in her 80s, and she moved. She moved a couple hours away, and she wanted to be by her children. And so apparently she and her child called around and called 16 different physicians in the area, and not one would take her on as a patient because she has chronic pain. That's pretty isolating. That's pretty isolating when you are in your 80s and you cannot find a doctor to take care of you because you have pain. That's isolating. You know, if they want to talk about isolation and shame, it's the system. It's you guys that make us feel isolated and full of shame. We're the ones that are made to feel bad when we go to the ER and they ask us what we're taking so they can take a med list so they can treat us. And they find out what kind of pain meds we're on, and they look at us like, oh, that is isolating. That's what causes shame. So if you want to fix the isolation and shame that we face every day, you're going to get together with your colleagues and tell them to get off their high horse and to start being nice. We didn't ask for this. Do you think I asked for this? Do you think my friends on Twitter asked for this? No. None of us did. But no, we have to sit here and put up with this because it's the only way we're going to get treatment. We're not allowed to say anything. We're not allowed to complain. We're not allowed to stand up for ourselves because then guess what will happen? I'll tell you what will happen. We'll leave the room and they'll go to our chart. Patient is non-compliant. Patient has a problem. Damn right I have a problem. This person is not okay. This person is, something's wrong. Something's wrong. You guys, the ones that are supposed to be treating us are the ones that make us feel isolated and full of shame. We're just human beings. We just want our pain treated. And the CDC guidelines have done nothing to help us remain in a position where we can get adequate treatment. And I'm tired of it. I'm tired of going on Twitter every single day and seeing people that I've met suffering, who have nothing, who are losing everything, their dignity, their self-respect, their self-worth, their happiness, their ability to love, their ability to have a life. You guys need to stop it. If you want to do something about this opioid epidemic, I'll tell you what right now. You need to get yourself off your high horse and go down to where illegal drugs are being sold and help either the people addicted to them or put a stop to the flow of those drugs in our country. That's what's going to help these people. Look at the socioeconomic factors that have caused people to become so downtrodden and oppressed that they are beyond hope. They have no hope. Look at, give them education, give them a job. Give them something to hang on to, something that makes their life worth living. They're suffering. That's a big part of what drives addiction in my heart. I'm no specialist. I don't know a lot about addiction, but I'm telling you that's what I see. It's not pain patients. It's not us, but we're being blamed. And I'm tired of it. So, back to the retreat. You know, it's very lovely that this doctor coordinated this, and I think her heart is absolutely in the right place. And I'm telling you, this is why people take vacations. Yes, these people went on a really cool vacation. And they did things that were spiritual, yoga, stretching, conversation. That would help anybody. But it's not a substitute for my medication. So please realize that we will benefit from these alternative therapies. We will. But we need to have pain relief while we're doing it. That's what's going to enable us to benefit from physical therapy, from talk therapy, from massage, acupuncture, whatever it is you want to try. It will help. It will help us. But you guys act like it's a meaningful substitute. That, oh yeah, all she has to do is put that bottle down and get up over here and do her exercise and she's going to be better. No. No, I'm telling you, it doesn't work like that. These people expressed anxiety about being terrible romantic partners and fears for being judged for the prescriptions that they take. Yep, because we are. And until we change that narrative, until we stop damning people for having pain and damning people for suffering from addiction, we're going to just keep on doing this. This is going to keep on keeping on. That's exactly what's going to happen. You know it, and I know it. All that stress that's put on these people, put on people like me, people like you, that's not good. Right now I can feel I'm like this because I'm emotional. Because I want to keep access to my treatment that enables me to be a mother, to be a wife, to get up on here and advocate for us and our rights. That's what I'm fighting for. And I'm not going to stop. You know, I've deviated from this article, but I'm telling you what, at the end of it, it talks about how Tennessee had this drug bring back day and how they collected 68,000 pounds of pills. Cool. Way to go, guys. I'm telling you right now, that flies in the face of your theory that when somebody goes to the ER and has their gallbladder removed, has a broken bone fixed, or is treated for being in a car accident, that they become out of control. They don't. Because if they did, they wouldn't be bringing back all these meds. I want you to think about that. So congratulations on the drug bring back day. I think that's great. We want to get the extra meds out of circulation. Bring your blood pressure pills, bring your whatever it is you don't need to take anymore, because apparently it's not good to put them in the water system. Bring them back, everybody. Bring them back. I think that's great. But just think about it. You people that are in charge of the government, when you see that many coming back, that right there should tell you that these people aren't ending up addicted. So stop not treating people when they go to the hospital and they need your help. That's what I'd like to see. That's what I'd like to see. I want to see a stop in all these stories of people in agony, reaching out, begging for help, and told, take Tylenol. Or better yet, 2-Bufferin. Peace out.